This deep dive is specially produced by the Critical Care Education Foundation's Knowledge Hub project for you, with the intention of providing a learning opportunity for doctors. It supplements the other material and self-assessments available on the CCEF Knowledge Hub project. We'll keep to the point, focusing tightly on the topic of subarachnoid hemorrhage. So let's jump right into what is really one of the most critical neurological emergencies you might encounter: subarachnoid hemorrhage, or SAH. This isn't just, another item on the differential diagnosis list. It's a true crisis, evolving rapidly, and it demands a really deep, nuanced understanding. Our goal today is basically to cut through the complexity, pull out the most vital, clinically useful information from our source material, and give you a solid, comprehensive overview. We want to focus on the core knowledge that every medical professional really needs when they're facing these challenging cases. Okay, so let's unpack this. What is SAH? Fundamentally, well, it's bleeding, right? Bleeding directly into the cerebrospinal fluid, it's CSF, specifically in those spaces around the brain, between the arachnoid and pia mater layers. But here's the crucial part, the so what. While the location defines it, the treatment, the complications that can spiral from it, and ultimately your patient's outcome, well, those are incredibly variable.
That's exactly right. It all hinges on the underlying cause. And what really stands out from the sources is just how common aneurysmal SAH, or ASAH, is. It's not just common, it's the dominant form.
Right, it accounts for something like 80% of non-traumatic cases.
Yeah, around 80% of non-traumatic SAH and maybe 3% of all strokes. It happens when a cerebral aneurysm, basically a weak ballooned out spot on an artery wall, ruptures. And when we talk aneurysms here, we're mostly talking about secular aneurysms. You might hear them called berry aneurysms. They're structurally weak. They lack the normal muscular layer and elastic tissue that healthy vessels have.
Making them really vulnerable to bursting under pressure.
Exactly. And location-wise, they have preferred spots. About 85% are in the anterior circulation, typically right at bifurcations in the circle of Willis. Think the junction of the anterior cerebral and anterior communicating arteries, or where the posterior communicating artery comes off, or the middle cerebral artery trifurcation. Those are classic locations.
So knowing where they often are helps, but why do they form? And maybe more importantly, why do they rupture? The sources point to some key risk factors, right? Things clinicians should definitely have on their radar.
Definitely. Hypertension is a big one. Cigarette smoking, significant alcohol consumption too. And acutely, things like amphetamine or cocaine use can be a trigger for rupture.
So lifestyle factors, but also maybe underlying conditions.
Yes, absolutely. There are genetic links and systemic factors too. Things like connective tissue diseases, polycystic kidney disease, Marfan syndrome, Ehlers-Danlos, also neurofibromatosis 1, fibromuscular dysplasia, even coarctation of the aorta. And it's quite striking, something like 7 to 20% of ACH patients actually have a family history of intracranial aneurysms. Modern genomics is helping us identify specific genetic loci involved too. So family history really matters.
Okay, so aneurysms are the main culprit, clearly. But not all SAH is aneurysmal. What about the other cases?
Right, that's non-aneurysmal SAH. That's the diagnosis when you do the workup, maybe even repeat imaging, and you just don't find an aneurysm, or you find another clear cause.
Like what sorts of causes?
Well, you might find a vascular malformation, like an AVM, or it could be related to cerebral amyloid angiopathy, especially in older patients. Reversible cerebral vasoconstriction syndrome, RCVS, is another one. And importantly, traumatic SAH from head injury is actually the most common non-aneurysmal cause overall. So history is key.
Always comes back to the history.
And within that non-aneurysmal group, there's a specific type worth mentioning: perimesencephalic SAH. Here, the blood is really localized, mainly in the cisterns around the midbrain and pons.
And that one tends to be less severe.
Generally, yes. Often, you don't find a specific cause, and the clinical course is typically much more benign than ASAH. It makes up maybe just under 6% of all SAH. Recognizing it is important because it can spare patients a lot of invasive investigation.
Okay, let's look at the bigger picture then, the epidemiology. How common is this?
The overall incidence is around 9 per 100,000 people per year. But that number really climbs with age. It can get as high as 31 per 100,000 in those over 85. The median age for aneurysmal SAH is around 53.
So often striking people in their middle productive years.
Exactly. And there's a definite gender difference too. About 2/3 of patients are women.
Wow, 2/3. And the outcomes? Unfortunately, they can be quite grim, right?
They really can be. Mortality rates for ruptured SAH are sobering, somewhere between 32% and 44%. It really highlights how life-threatening this is from the outset.
Yeah, the sources mentioned something like 12% are immediately fatal.
Yes, about 12% don't even make it to the hospital. The 28-day mortality is around 35%, and even in-hospital mortality is still high, about 18%. And the highest risk period, that's early rebleeding, that's often fatal.
And there are specific populations at even higher risk.
Pregnancy is a key one. The risk goes up significantly in the third trimester. And tragically, ASAH is a major cause of maternal mortality, responsible for something like 6 to 25% of maternal deaths. So that's sudden severe headache in a pregnant patient. High alert for SAH.
Okay, so we know what it is, who gets it. Let's talk pathophysiology. How does it actually happen? We said bleeding into the subarachnoid space.
Right, that's the core event. But the blood doesn't always stay confined there. It can extend into the brain tissue itself, causing an intracerebral hemorrhage, or into the ventricles, intraventricular hemorrhage, or even into the subdural space. Each of those makes things more complicated.
And the rupture itself, what happens then?
When that aneurysm bursts, you get this jet of blood hitting the surrounding tissue, causing direct damage. But critically, there's also this sudden, massive, albeit brief, spike in intracranial pressure, ICP. It can momentarily shoot up to match arterial pressure.
And that ICP spike explains some of the initial symptoms.
Precisely. It's key to understanding why patients present the way they do. Remember, those saccular or berry aneurysms are typically these small, round, weak spots, usually at those artery branching points in the circle of Willis.
Which leads us perfectly into clinical presentation. How do these patients actually look? What are the signs we need to catch? You mentioned that ICP spike.
Yes, but sometimes there's a warning sign before the major rupture. It's called a sentinel or warning hemorrhage. Happens in maybe 20% of patients.
What does that look like?
It's usually a sudden severe headache, maybe with some neck stiffness, meningismus. The key is it often lasts for at least 48 hours in most of these cases. The real danger here is that it gets missed.
Dismissed as a migraine or something.
Exactly, or a tension headache. But if you miss it, the patient might go on to have a massive, devastating bleed days or weeks later. So a high index of suspicion for that kind of headache is crucial. It's a chance to intervene before disaster strikes.
And then the major hemorrhage itself, the classic sign.
The classic sign, the one that should immediately scream SAH, is that sudden, incredibly severe headache. Over 90% of patients experience this. They'll often describe it quite literally as the worst headache of their life.
And it comes on instantly.
Abruptly, often reaching peak intensity in just seconds. It's not gradual. Alongside that, you'll often see neck pain, that neutral rigidity from meningeal irritation, nausea, vomiting, dizziness.
Double vision, light sensitivity.
Yeah, diplopia, photophobia, and just profound lethargy are common too.
And loss of consciousness. You mentioned that ties back to the ICP spike.
Right. That happens in almost half the patients, about 45%, right at the time of rupture. It's either the sudden ICP rise or sometimes cardiac arrhythmia is triggered by the event. You might also see things like an abducens nerve palsy, the sixth nerve, which also reflects that acute pressure rise.
What about seizures?
Early seizures can happen, maybe 8–11% of cases, also often related to the ICP spike. But it's important to note they don't necessarily tell you where the rupture is or how severe the bleed is overall.
Okay, so the patient presents, you suspect SAH. Grading this severity seems really important next for prognosis and deciding treatment.
Absolutely vital. There are a couple of key scales we use. The Hunt and Hess scale is a clinical one. It basically correlates how the patient looks clinically with their prognosis.
Can you walk us through that quickly?
Sure. It goes from gray to I, asymptomatic or just minimal headache, maybe slight neck stiffness, pretty good prognosis, 11% mortality, all the way up to grade V.
Grade V being the worst.
Yeah. Deep coma, decerebrate posturing, basically moribund. 100% mortality there. Grades 2, 3, and 4 fall in between with increasing neurological deficits and worsening mortality 26%, 37%, and 71% respectively. And a really important point the sources make, if the patient has serious underlying medical problems, bad hypertension, diabetes, severe arteriosclerosis, they automatically get bumped up to the next less favorable grade. Comorbidities matter.
Okay, that's Hunt and Hess. Then there's the WFNS scale,
Yep.
World Federation of Neurological Surgeons.
Right. That one's a bit more objective, maybe. It uses the Glasgow Coma Scale, the GCS, and whether or not there's a motor deficit. It gives an estimate of the risk of a poor outcome, like severe disability or death.
How does that break down?
Grade 1 is GCS 15, no motor deficit, about 13% risk of poor outcome. Grade 5 is GCS 3-6. With or without a motor deficit, that risk jumps way up to 68%. Again, it gives you a quick way to gauge severity and communicate it.
So those are clinical scales. What about imaging? I know there's a radiological scale, too.
Yes, the modified Fisher scale. This one's used all the time. It looks at the amount and distribution of blood on the initial CT scan, specifically to predict the risk of vasospasm, which is a major complication we'll definitely get into.
More blood means higher risk.
Essentially, yes. It looks at whether the SAH is thick or thin, diffuse or localized, and whether there's blood in the ventricles, IVH. Grade 1 is minimal blood, no IVH, about a 24% risk of symptomatic vasospasm. Grade 4 is thick SAH, and IVH present that risk climbs to 40%. It helps you anticipate who needs closer monitoring for vasospasm.
Okay, makes sense. So moving to diagnosis, what's the workup?
It needs to be fast. The first step is almost always a non-contrast head CT. That's your go-to emergent scan.
How good is it at picking up the blood?
Very good early on. Sensitivity is near 100% in the first 6 to 12 hours, still over 90% at 24 hours. But, and this is key, it drops off significantly after that. By day 5, it might only be 50% sensitive, so timing is critical.
And you're looking for that bright white signal of blood in the cisterns, the fissures?
Exactly. Basal cisterns, Sylvian fissures, sulci. You might also see hydrocephalus if the blood is blocking CSF flow.
What if the CT is negative, but you still think it's SAH based on the story?
Then you move to a lumbar puncture, an LP. Assuming no contraindications, of course. If your clinical suspicion is high, a negative CT doesn't rule it out, especially if it's been a day or two since onset.
And the key finding on LP?
Xanthochromia. That's the yellowish tinge to the CSF from red blood cell breakdown. It takes a couple of hours to develop after the bleed, but can last up to 2 weeks. You'll also typically see high protein, maybe slightly low glucose, and usually a high opening pressure.
Okay, so CT confirms SAH, or LP does. Now you need to find the source, usually an aneurysm. What's next?
CT angiogram, or CTA, is usually the first non-invasive test to look for the aneurysm. It's quick, widely available, and has really high sensitivity and specificity, over 98% generally.
Any limitations?
Yeah, it's less sensitive for very small aneurysms, say less than 5 millimeters. MRA can be an alternative, but it's often less practical in the acute setting.
So CTA is often the first look. But what's the definitive test?
The gold standard is still 4-vessel cerebral angiography, often called a digital subtraction angiogram or DSA. This gives you the most detailed pictures of the brain's blood vessels.
Why is it the gold standard?
It's the best for precisely locating the ruptured aneurysm, assessing for vasospasm at the same time, and crucially, looking for any other unruptured aneurysms, which isn't uncommon. Ideally, you do this as soon as possible.
And sometimes you do the treatment right then and there.
Exactly. Often, the angiography and the endovascular treatment, like coiling, happen in the same procedure. And another important point. If the first angiogram is negative, but you strongly suspect an aneurysm, you might need to repeat it in a week or 2. Sometimes spasm or clot can hide the aneurysm initially.
Right. Need to be persistent. Okay, let's pivot to management. SAH confirmed. Aneurysm likely identified.
Yeah.
What are the immediate priorities?
Priority 1, 2, and 3 is basically secure the aneurysm. Early treatment, whether it's endovascular coiling or surgical clipping, is absolutely paramount.
Why so urgent?
To prevent rebleeding. As we said, rebleeding is incredibly dangerous, carries a massive mortality risk. It's a race against time to get that aneurysm secured.
Coiling versus clipping is one generally preferred now.
In many cases, yes. Endovascular coiling is often preferred, especially if it can be done quickly within the first 48 hours. Large trials have shown it's associated with better long-term outcomes, like being alive and independent at 10 years.
Any downsides to coiling?
Well, there's a slightly higher risk of rebleeding later on, though it's still very low. And coiling does have a higher rate of the aneurysm recurring on follow-up imaging, sometimes needing more treatment down the line. Clipping is still very important, especially for certain aneurysm shapes or locations. It's really a decision made by the multidisciplinary team based on the specifics.
Which really emphasizes the need for specialized care, doesn't it?
Absolutely. The sources strongly recommend getting these patients to high-volume SAH centers, places that treat, say, more than 35 cases a year. They have the experienced teams, neurosurgeons, neurointensivists, interventional radiologists, and the outcomes are demonstrably better.
Makes sense. So once they're in that specialized ICU setting, what's the routine care like?
It's intensive. Constant neurological checks, close hemodynamic monitoring blood pressure, heart rate continuous ECG, Frequent electrolyte checks, monitoring fluid balance, body weight. You elevate the head of the bed to help venous drainage from the brain and lower ICP. Good pulmonary care to prevent lung issues. Every detail matters.
And pain. That terrible headache must linger.
It often does, sometimes for weeks due to the meningeal irritation. Opiates are usually needed. Interestingly, some sources mention that corticosteroids like dexamethasone might help if the meningitic symptoms are really refractory.
Okay, that covers initial management. Now the complications. This seems to be where things get really complex. Rebleeding is the first big threat.
It's the most immediate and feared one before the aneurysm is secured. The risk is highest in the first 24 hours, maybe 5.8% risk in that first day, with a devastating 57% mortality if it happens then. Overall, maybe up to a third of patients rebleed if untreated, with mortality up to 70%.
How do you recognize it?
It's usually dramatic. Sudden worsening of headache, a new seizure, more nausea vomiting, a drop in consciousness, new neurological deficits. Risk factors include things like high blood pressure, big swings in blood pressure, having a seizure or LOC at the initial onset, large aneurysm size, poor clinical grade, and just the time waiting for treatment. Secure it fast.
Which brings us back to blood pressure control. How do you manage that before the aneurysm is fixed?
Carefully. The general recommendation is to keep systolic blood pressure below 160 millimeter Hg. You use short-acting titratable IV meds like nicardipine or labetalol, but you have to balance that against potentially worsening brain perfusion if the pressure drops too low, especially if ICP is high. It's a balancing act.
And after the aneurysm is secured?
Then the game changes. You generally allow blood pressure to rise, sometimes even induce hypertension. Why? Because the main concern shifts to vasospasm and delayed cerebral ischemia. Higher pressure can help push blood through those narrowed vessels.
What about patients on blood thinners?
Stop them immediately. All antithrombotics out. If they're on warfarin, you reverse urgently with IV vitamin K and clotting factors, usually PCC. For the newer anticoagulants, the NOACs, you use specific reversal agents if available, like idarucizumab for dabigatran or endexina alpha for the factor XA inhibitors.
Okay, and antifibrinolytics. Things like TXA to reduce rebleeding. What's the current thinking there?
That's evolved a bit. There were concerns they might increase vasospasm or hydrocephalus, but newer evidence suggests that a short course of TXA, given just until the aneurysm is secured ideally within 72 hours, does reduce rebleeding without significantly increasing delayed ischemia. So short-term use is often considered now.
The other measures, bed rest.
Strict to bed rest, yeah. Minimize stimulation, quiet, dark room, careful sedation if needed. And stool softeners are important. You want to avoid straining anything that raises ICP.
Okay, so rebleeding is the early threat. What's the next big worry?
Cerebral vasospasm, CVSP, leading to delayed cerebral ischemia, DCI. This is probably the major cause of death and disability in patients who survived the initial bleed.
And this happens later?
Typically, yes. It usually starts around day 3 after the SAH, peaks somewhere between days 4 and 12, but can sometimes linger for up to 3 weeks. It's basically a narrowing of the cerebral arteries, triggered by the breakdown products of the blood in the subarachnoid space.
And not all vasospasm causes problems.
Right. You can see it on imaging, but what really matters is symptomatic vasospasm, the kind that actually reduces blood flow enough to cause brain injury. That's DCI.
So how do you watch for it?
Vigilant neurological exams are key. Subtle changes, new confusion, focal weakness, speech problems can be the first sign. We also use transcranial Doppler, TCD, ultrasound, usually daily or every other day. It measures blood flow velocities in the brain arteries. High velocities can predict vasospasm, sometimes before symptoms start.
And who's most at risk?
It correlates strongly with the patient's clinical condition on admission, worse grade, higher risk, and, as we mentioned with the modified Fisher scale, the amount of blood seen on the initial CT. More blood, more irritation, more risk of vasospasm.
Is there anything you can do to prevent it?
Yes, the one proven medication is nimodipine. It's a calcium channel blocker given orally 60 milligrams every 4 hours for 21 days straight for all patients with aneurysmal SAH.
Does it actually stop the arteries from narrowing?
Interestingly, no. It improves neurological outcomes from vasospasm, but doesn't seem to prevent the large vessel narrowing itself. The benefit might be through neuroprotection or improving microcirculation. The main side effect you watch for is hypotension.
What else for prevention? Fluids?
Maintaining normal fluid volume euvolemia is crucial. Avoid dehydration at all costs. But importantly, prophylactic hypervolemia or induced hypertension are not recommended anymore. They don't prevent vasospasm and can cause complications, and hemodilution is definitely out.
Okay, so nimodipine and euvolemia for prevention. What if symptomatic vasospasm, or DCI, actually happens? How do you treat it?
That's when you might initiate Triple H therapy, though it's often modified now, mainly focusing on hypertension and maintaining hypervolemia or maybe just euvolemia. The idea is to medically raise the blood pressure to force more blood through those narrowed vessels.
Sounds risky.
It is. You have to watch very carefully for fluid overload, pulmonary edema, heart failure, even worsening brain swelling. It requires intensive ICU monitoring and careful titration based on the patient's neurological response.
Are there other treatments if that doesn't work?
Yes, endovascular options. You can do an angiogram and infuse vasodilators like verapamil or nicardipine directly into the spasming arteries. Or, in severe cases, you can perform balloon angioplasty to physically stretch the narrowed vessel open.
And draining CSF can help too.
It seems to. CSF drainage, either via a ventricular drain or a lumbar drain, can sometimes improve vasospasm, possibly by removing some of the irritating blood breakdown products. And managing anemia, keeping the hemoglobin maybe closer to 10 GDL, is often recommended for patients with or at high risk of ischemia.
Okay, moving on from vasospasm, what about seizures? Are they common?
They can be. Risk is maybe up to 27% overall, highest in the first 24 hours. More common if the aneurysm was in the middle cerebral artery or if there was a lot of blood clot.
So, do you routinely give anti-seizure meds?
Prophylaxis is generally indicated before the aneurysm is secured, usually with something like levetiracetam or phenytoin. It's an important early step.
But not long-term.
Generally, no. Guidelines recommend stopping the prophylaxis once the aneurysm is secured, unless the patient actually had a seizure or remains at very high risk, like being comatose. There's actually evidence, particularly for phenytoin, that long-term use might worsen neurological recovery. So short-term prophylaxis is key, then reassess.
Got it. Another complication is hydrocephalus, right? Water on the brain.
Yes, buildup of CSF. It can happen acutely, right after the bleed, if blood clots block the normal CSF pathways or impair absorption. Or it can develop subacutely over days to weeks. There's even a delayed normal pressure form that can show up weeks later with gait problems and cognitive issues.
How does it present acutely?
Usually with worsening lethargy, maybe problems with upward gaze, just a general decline in consciousness. It's due to the rising intracranial pressure from the CSF buildup.
And the treatment is drainage.
Primarily, yes. If the patient is deteriorating due to hydrocephalus, you typically place a ventricular drain, an EVD, to divert the CSF. Sometimes repeated lumbar punctures can help too. And importantly, doing this, even if the aneurysm isn't secured yet, doesn't seem to significantly increase the rebleeding risk.
That's a key point. What about that delayed form?
If chronic hydrocephalus develops, they might eventually need a permanent ventriculoperitoneal or VP shunt. And here's a really crucial clinical point. If a patient has significant hydrocephalus causing high ICP, you generally don't treat their hypertension aggressively until the hydrocephalus is managed. That high blood pressure might actually be needed to maintain brain perfusion against the high ICP. Treat the hydrocephalus first.
Wow, so many neurological balls to juggle. What about systemic problems? Do they happen often?
Very common, especially in patients with high-grade SAH, usually in the first few days. It's often driven by that massive sympathetic surge, the catecholamine storm, that happens at rupture.
Leading to heart problems.
Yes, cardiac dysrhythmias are frequent, maybe 28–40% of patients. You often see ECG changes, ST depression, T-wave inversion that look like ischemia but are actually neurogenic and don't necessarily mean coronary artery disease.
And that stress cardiomyopathy.
Takotsubo. Exactly. Takotsubo cardiomyopathy is a transient stunning of the left ventricle causing heart failure symptoms. It usually resolves within a few days with supportive care. You can also see neurogenic pulmonary edema, sudden severe lung fluid buildup, again from that sympathetic drive. It can cause profound hypoxemia, but is also usually transient, resolving in 24–48 hours.
So the key is supportive care for these.
Absolutely. Recognize they're likely neurogenic, provide aggressive ICU support, manage arrhythmias, support blood pressure, provide respiratory support because they are usually reversible.
Okay, almost there. Any other general ICU management points specific to SAH?
Hyponatremia is a big one. Low sodium happens in about 30% of cases. The critical thing is to figure out why. Most often in SAH, it's cerebral salt wasting, CSW, where the brain signals the kidneys to dump salt and water. Less often, it's SIADH.
And the treatment is different.
Completely different, and getting it wrong is dangerous. For SIADH, you typically fluid restrict, but fluid restriction is absolutely contraindicated in SAH because it can worsen vasospasm. So if it is SIADH, you treat with hypertonic saline while keeping the patient euvolemic. If it's CSW, which is more common and causes volume depletion, the treatment is isotonic fluids, maybe even salt tabs or fludrocortisone. Close monitoring of sodium, osmolality, and volume status is essential.
That's a huge pitfall to avoid. What about blood clots, VTE?
High risk. Pneumatic compression boots should go on immediately. Any existing anticoagulants are stopped, as we said. Then, once the aneurysm is secured, you start subcutaneous heparin for VTE prophylaxis, assuming no contraindications. Watch out for HIT, though heparin-induced thrombocytopenia affects about 6% of SAH patients.
And things like fever, blood sugar, anemia.
Fever is common, linked to worse outcomes, but treating the fever itself hasn't been proven to improve outcomes yet. Anemia, especially HB below 9 GDL, is also associated with worse outcomes, though the ideal target isn't perfectly clear. Maybe aim a bit higher, near 10, if ischemia is a concern. Hyperglycemia, blood sugar over 200 milli-GDL, is bad too. Treat it, but avoid hypoglycemia carefully. Basic ICU care, but with heightened importance in SAH.
Okay, so bringing this all together, it's clear that subarachnoid hemorrhage is just incredibly complex, a real critical care challenge. We've covered a lot of different causes, especially aneurysms, the classic worst headache presentation, those vital grading scales like Hunt and Hess and modified Fisher, and then this whole cascade of management steps and potential complications.
Yeah, from securing the aneurysm immediately to prevent rebleeding, to the constant vigilance needed for vasospasm, managing hydrocephalus, seizures, those tricky electrolyte issues like hyponatremia, and the systemic complications. It's a multi-system illness triggered by a brain event.
And despite all these advances, the prognosis can still be pretty tough.
It really can. Even with treatment, mortality is still significant, maybe 20–40% for those who make it to the hospital, and achieving a good neurological recovery. Less than a third of patients manage that. Predictors of a poor outcome really highlight the severity. Being unconscious or in poor neurological shape on arrival, older age, underlying hypertension or other illnesses, seeing a lot of blood on the initial CT, having seizures, brain swelling, having the aneurysm in the posterior circulation like the basilar artery, and developing symptomatic vasospasm. These factors weigh heavily.
And thinking long-term, even for survivors, if that aneurysm isn't fixed, the danger isn't completely gone, is it?
No, that's a crucial final thought. For survivors with an unrepaired aneurysm, there's roughly a 3% risk per year of it re-rupturing. It really underscores why definitive treatment of the aneurysm is so critical. The threat can linger for a lifetime otherwise.
A really sobering reminder of the long shadow this condition can cast. Well, this has been a very comprehensive deep dive. It was designed as a targeted learning opportunity for you, the doctors listening. We hope distilling this information has been valuable. And we definitely encourage you to keep exploring and use the self-assessment tools available through the Critical Care Education Foundation's Knowledge Hub project.